It's my pleasure to welcome you all to this IAEA-WHO joint webinar on EPR Medical Management and Response. My name is Ramon de la Vega, and I am the Emergency Preparedness Coordinator of the IAEA's Incident and Emergency Center. The IAEA-IEC is the global focal point for emergency preparedness and response to nuclear or radiological emergencies, irrespective of the cause. The IEC also supports member states in strengthening their national emergency preparedness and response to nuclear arrangements to nuclear or radiological emergencies. Despite the pandemic conditions, the IEC has been and will continue organizing webinars and virtual training events on different areas related to emergency preparedness and response to assist member states build a well-sustained emergency preparedness and response program based on a competent generation of experts. Today's webinar will feature on revision of the EPR Medical generic procedures for medical response during a nuclear radiological emergency, which will be published soon. After a nuclear radiological emergency occurs, safety and security measures aiming at the protection of human life, health, and the environment are essential. From the medical perspective, the identification of individuals with possible radiological contamination and individuals who have possibly received significant radiation exposure that may lead to induced health effects is very important, as well as the provision of appropriate medical attention. In 2005, the IAEA published a publication on generic procedures for medical response during a nuclear radiological emergency, EPR Medical 2005, co-sponsored by the WHO, in order to help contribute to a coherent international response to nuclear radiological emergencies from the medical perspective. This new publication that we just developed recently supersedes EPR Medical 2005. Its content has been updated in line with the relevant IAEA safety standards published since 2005, in particular GSR+7, which was also co-sponsored by WHO. We hope this publication will be a useful tool for different organizations and professionals that could be involved in the medical preparedness and response for a nuclear radiological emergency, including medical personnel, first responders, healthcare providers, health authorities, and policymakers for emergency management. During the webinar today, you will hear about the knowledge on present fundamentals on the medical handling of individuals exposed to ionizing radiation at pre-hospital and hospital levels, and medical management of internal contamination. I'd like to thank the experts joining us today, Mrs. Zhanat Carr, Mr. Eduardo Herrera Reyes, Mr. Hideo Tasusaki, and Mr. Nicholas Dianiak for the willingness to support the IEC in delivering this webinar. They all contributed to the new EPR Medical publication and have a detailed knowledge of the IAEA Emergency Preparedness and Response Program and extended experience in lecturing in webinars and other events. I would also like to express my appreciation to WHO for co-hosting this webinar. The IAEA cooperates with the WHO, among others, in the area of radiation medicine and of radiological safety, security, and emergencies. In terms of nuclear or radiological emergency, IEC and WHO are engaged to a cooperative relationship under the framework of the Interagency Committee for Radiological and Nuclear Emergency, IARCNE. We are happy to continue this fruitful relationship with WHO. As a final note, I would like to thank you all for being here today, and I wish you a fruitful and productive outcome for this webinar. Thank you, Mai, and over to you.
Thank you very much, Ramon, for giving us opening remarks. So before starting my presentation, I would like to explain about a few logistic issues and introduce program on this webinar. So please wait, I will share my screen. Okay. So all the participants should communicate through the chat. Questions on the presentation can be posted at any time on the chat as a message to host or everyone. There will be time for replying questions at Q&As and discussion section. This webinar is being recorded. We share the presentation and link to watch the record through SharePfonet page, which is IAEA provided. Kindly note that you will need a Nucleus account to access SharePfonet. We will inform detail how to get presentations and link to watch the record after implementing this webinar via email. The aim of the IAEA-WHO joint webinar is to provide the medical management of nuclear or radiological emergencies in an efficient and coordinated manner. This webinar will cover topics featured on the revision of EPR Medical, generic procedures for medical response during nuclear or radiological emergencies, which be in publication process. As Ramon said, in 2005, IAEA published a manual on this EPR Medical 2005, co-sponsored by WHO in order to help contribute to a coherent international response to nuclear or radiological emergencies. This new publication furthers EPR Medical 2005. Its content has been updated in line with the relevant IAEA safety standards published since 2005, particularly GSR Part 7. Other important publications have also taken into account, as have the changes and development based on lessons learned from the Fukushima Daiichi accident and other radiological emergencies. Following this introductory chapter, the second part, the overview, provides relevant information on definitions and the particular roles of the participants in the response to nuclear radiological emergencies. The section 2.6 is organized in individual sections based on an assumed medical response structure. It starts with the initiation of the formal emergency medical response at the pre-hospital level and concludes with guidance on the provision of mental health support to those involved in the response. Each section contains generic implementing procedures, and each of them is organized in the order that actions will most likely be performed. This publication also contains worksheet and appendix to provide additional information supporting the medical response to nuclear or radiological emergencies. This slide shows the webinar program. Firstly, I will talk about overview of emergency medical response. And secondly, Dr. Zhanat will be presented WHO role in supporting global radiological and nuclear emergency preparedness. And then Dr. Herrera Reyes will be lecturing on medical management at pre-hospital levels. And then Dr. Hideo Tatsuzaki we're talking on hospital preparedness and risk management. And lastly, Dr. Daniak will lecturing on approach to the diagnosis and management of internal contamination. And after these lectures, we will take a time to discuss for about 20 minutes. So I would like to introduce IAEA publications for the EPR medical area just for your reference. We can see and download these publications on the following URL on IAEA website for free. These publications focus on medical management, internal contamination, and biodosimetry. The publications shown in the bottom line are new. These two publications are quick reference guide for medical physicists supporting the response to nuclear and radiological emergencies. The next right one this is a safety report series is focused on medical management of radiation injuries. And the next one, this is a case report of radiation accident in Ventanilla. In addition, a revision of EPR Medical and EPR Medical follow-up will be published soon. Lastly, I would like to introduce one more course, e-learning courses. It consists of the 6 online modules related to generalities, a basic concept on radiation protection, arrangement on medical preparedness and response, and medical management of individuals involved in nuclear or radiological emergencies. If you are interested in this, please use this online module. So this is that's all I have to say about the logistic and the introduction. Okay. So if you are any problems, please let me know on the chat. Okay. So please wait. Okay. Okay. So let's move to my presentation. So today I'll be talking about the overview of emergency medical response. I appreciate the opportunity to give this presentation. As you already know, as defined IAEA Safety Glossary 2007 edition, a nuclear or radiological emergency is a non-routine situation that necessitates prompt action, primarily to mitigate a hazard or adverse consequences for human health and safety, quality of life, property, or the environment, and if there is a hazard due to the energy resulting from a nuclear chain reaction or from the decay of the product of the chain reaction or radiation exposure. This slide shows the estimated number of worldwide major radiation accidents along with the percentual distribution of accidents from 1944 to 2016. Emergencies related to industrial sources may occur when proper industrial radiography procedures are not followed. Failure to use exposure control may lead to inadvertent overexposure to workers in the immediate work area. Accidental medical overexposure may occur because of miscalculation of the activity of the therapy source, improper infection of an X-ray device or accelerator, or higher activities than intended inadvertently administered during diagnosis and therapy. A lost or stolen sources is a case of emergency involving radioactive material. The risk of the public will depend mainly on the total activity involved and the length of time that people may be exposed to the source. IAEA Safety Standards GSR Part 3 and Part 7 provides a general guidance regarding the framework of activities related to radiation protection and preparedness and response to nuclear or radiological emergencies. Safety requirements are binding on the IAEA Secretariat in relation to its own operations and on member states in relation to operations assisted by IAEA. They are recommended for use by member states and by national authorities in relation to their own activities. Managing the medical response in a nuclear or radiological emergency is described in Requirement 12 of GSR Part 7. The main goal of this requirement is that the government shall ensure that arrangements are in place for the provision of appropriate medical screening and triage, medical treatment, and longer-term medical actions for those people who could be affected in a nuclear or radiological emergency. For the implementation of the Requirement 12, several aspects should be considered: human resources, authorities' involvement, infrastructure, guidance, and so on. From this slide, I would like to talk the description on the medical response in line with Requirement 12 on GSR Part 7. This requirement consists of 7 articles from 5.62 to 68. In 5.62, on the presentation by an individual of a clinical symptom of radiation exposure or other indications associated with possible nuclear or radiological emergency, the medical personnel or other responsible parties who identify the clinical symptoms or their indications shall notify The appropriate local or national officials and shall take response actions as appropriate. First measure is to get as much information as possible, but without causing an acceptable delay on the activation of the hospital response plan. In 5.63, this is vanished. In 5.63, arrangements shall be made for the medical personnel, both general practitioners and emergency medical staff, to be made aware of the clinical symptoms of radiation exposure, and the appropriate notification procedures and other emergency response actions to be taken if a nuclear or radiological emergency arises or is suspected. With radioactive materials, there are several combinations of both injured and uninjured victims that can result. This slide bottom contemplates all possible possibilities. In 5.64, in 5.64, arrangements shall be made so that in a nuclear or radiological emergency, individuals with possible contamination can promptly be given appropriate medical attention. These arrangements shall include ensuring that transport services are provided where needed and providing instructions which include surgical masks and gloves to medical personnel on the precautions to take. Treat life-threatening conditions first without regard to radiation or contamination. In case of handling contaminated patient, please note that it needs to isolate patient and restrict access to the treatment or evacuation area and maintain contamination control. While contaminated victims are handled and transported using contamination control procedures, exposed victims require no special handling. If there is any doubt, assume all victims are contaminated until proven otherwise. Continue medical assessment and treatment during the transport when necessary. In 5.65, for facilities in categories 1, 2, and 3, arrangements shall be made to manage an adequate number of any individuals with contamination or of any individuals who have been overexposed to radiation, including arrangement for first aid, the estimation of doses, medical transport, and initial medical treatment in predesignated medical facilities. In mass casualty emergency, it is necessary to implement provisions to assess the concerns of members of the public about possible radiological contamination. Conditions must exist for performing radiological triage of the large number of people at a location remote from the hospital. Individuals who are only externally contaminated but not injured should be decontaminated at a facility other than the hospital to conserve hospital resources for the injured. In 5.66, for area within the emergency planning zones, arrangements shall be made for performing medical screening and triage, and for assigning to a predesignated medical facility any individual exposed at levels exceeding the criteria. These arrangements shall include the use of pre-established operational criteria in accordance with the protection strategy. Triage is the sorting of patients into priority groups according to their needs and the resources available. Triage in radiation emergency should be based initially on the severity of medical conditions using conventional triage systems and not on radioactive exposure or contamination. Primary attention should always be aimed at life-threatening conditions. The second step is to identify the possibly exposed individuals for external exposure and radioactive contamination. In 5.67, arrangements shall be made to identify individuals with possible contamination and individuals who have possibly been sufficiently exposed for radiation-induced health effect to result, and to provide them with appropriate medical attention, including long-term medical follow-up, These arrangements shall include guidelines and designation of medical personnel trained and designation of institutions. The rules of government medical assistance in general determine the structure and preparedness that must exist in advance and must be capable of being put into operation at any moment for appropriate assistance to persons accidentally exposed to radiation. Awareness of need for advanced preparation of hospital in anticipation of possibly dealing with nuclear or radiological emergencies has been re-emphasized as consequences of past experiences like Guyana, Latin America, and Fukushima accidents. Therefore, any hospital that is a part of the overall response should have a well-elaborated and established emergency plan to be triggered whenever necessary. The last in 5.68, arrangements shall be made for the identification of individuals who are in those population groups that are at risk of sustaining increase in the incidence of cancers as a result of radiation exposure in the nuclear or radiological emergencies. Arrangements shall be made to take longer-term medical actions to detect the radiation-induced health effect among such population groups in time to allow for their effective treatment. These arrangements shall include the use of pre-established operational criteria in accordance with the protection strategy. The long-term medical follow-up of affected people involves performing regular medical examinations with the purpose of enabling early diagnosis and effective treatment of radiation-induced health effects. Depending on the type and scale of the radiation emergency, local or national health authorities may perform a more definitive assessment of doses for members of the public based on environmental measurement, geographical location, and exposure histories to determine if any members of the public will need long-term medical follow-up. So this is a summary for the implementation of the requirement 12. Several aspects should be considered. Planning and preparedness are essential for adequate medical response to radiation emergency. In addition, in order to be adequately prepared for events of nuclear and radiological emergency, medical doctors and responders need to complete dedicated training. We hope IAEA EPR publications, including revision of EPR Medical, which will be published soon, training courses and webinars will be useful tools for medical doctors and responders supporting response to nuclear and radiological emergencies. That's all from my side. Thank you very much. Okay, I will stop sharing. Okay, so let's move to the next lecture. Let me introduce the next lecturer, Dr. Zhanat. She is a medical doctor. Sorry, I moved to the presentation role, so please wait.
I will share my screen. Yeah.
Okay, thank you. Please wait. Okay, let me introduce Zhanat Carr. She is a medical doctor and works as a medical officer at the Radiation and Health Unit of the Department of Environment, Climate Change and Health at WHO. She is managing the area of preparedness response and medical follow-up at nuclear and radiological emergencies. She also contributed to preparing the EPR revision of EPR Medical, and WHO will be co-sponsor of this publication. She will be lecturing on WHO's role in strengthening global radiological and nuclear emergency preparedness. So, Dr. Zhanat, floor is yours.
Thank you very much, Mai. This is my great pleasure to join this webinar. And I also want to thank Ramon and IEC colleagues for their good cooperation, for bringing WHO in, for willing to work together on this very important topic. Before I start my presentation, Mai, could you please check your email, because Nicholas Deniak is having difficulty to connect, so he is asking to help him.
Okay, I will check.
Yeah, in the meantime, I'm sharing my screen. I hope you can see it. Can you see it?
Yes, we can see.
Okay. Okay, for those of you who are not familiar, I will just quickly mention that WHO is the dedicated UN agency for human health. It is a global leader on human health, obviously, as everybody is aware these days that WHO is fighting the global pandemic of COVID-19 worldwide, and it puts enormous responsibility and strain on the organization, on its staff, on its resources, etc. The organization goes back for more than 60 years, and our main objective is attainment by all people of the highest possible level of health. We are governed by the World Health Assembly, WHA, which is taking place this week in Geneva, virtually this time. And we have 6 regional offices worldwide and headquarters in Geneva, 150 country offices in 196 member states. We published a benchmark report in January this year, which actually looks back for 1 year of COVID response, and it's very well done, illustrated with infographics. I recommend you to take a look at this report through the link provided in this slide. More specifically related to radiation emergencies, there is a program called Radiation and Health within headquarters. We are located in the Division for Healthier Populations, within which we have a Department of Environment, Climate Change and Health. And within this department, there are different units dealing with different risk factors in the environment, so one of them being radiation. The area of work of our unit cover non-ionizing radiation, also ionizing radiation, natural, planned, and accidental exposures. And we support WHO's work in health emergencies department, which is a different part of the WHO, WHE division. We are the focal point for the Incident and Emergency Center of IAEA, and for other stakeholders for all matters related to radiological nuclear emergencies, preparedness, response, and recovery. We also contributed to the COVID response to the extent of our mandate. We supported the work on infodemic management. If you may remember that there were a number of rumors about UV use and also about 5G technology, and it's being blamed for COVID, etc. We developed a rapid advice guide on chest imaging for COVID-19 and technical specification for imaging equipment. And now, based on these 2 documents, there is a training package already developed, and it's available through the WHO Academy application on hand devices. More specifically, talking about radiological nuclear emergencies, obviously WHO is leading work on the outbreaks, and for other types of emergencies, there are specialized agencies, as you heard from Mai and from Ramon. Obviously, the radiological nuclear emergencies are led by IAEA, whereas WHO will support, provide the support and contribute and work together with IAEA on all matters related to public health and medical dimensions of these emergencies. We have a very firm legal framework for WHO's involvement in this area. First of all, it is our constitution and our relevant assembly resolutions. WHO is also full party to both international conventions on early notification and on assistance in case of a nuclear accident. And a very strong legal instrument is the international law called International Health Regulations, IHR, which was revised and in 2005 included in its scope radiation emergencies. We also follow the Sendai framework for disaster risk reduction, which was put in place in 2015 with a central focus on health. As Ramon already mentioned, we are a member of the Interagency Committee on Radiological Nuclear Emergencies. where some about 20 other international organizations participating, and our roles are described in this document, Joint Radiation Emergency Management Plan, where we provide a modus operandi for both preparedness activities, exercises, and also for emergencies. Of course, we work with other international partners, in addition to IACRINA members, and being involved with the relevant work of IAEA. We also work with NEA, Nuclear Energy Agency, which is part of OECD in Paris. We also work with Global Health Security Initiative, GHSI, Working Group on Radiological and Nuclear Threats. If you don't know what is this group, it consists of G7 countries plus Mexico, and it brings together Ministry of Health dealing with the health security. And we also participate in a number of regional partnerships. But one of our strongest tools for implementing our work are our partners in collaborating centers. These collaborating centers form specialized expert networks such as REMPAN network and BioDose network. This is a website which describes the Institute of Collaborating Centers, what they are, how to become a collaborating center, etc. REMPAN is Radiation Emergency Medical Preparedness and Assistance Network, was put in place in 1987, shortly after Chernobyl, and today it brings together more than 40 institutions and also some, maybe same number or more of individual observers. Here's a website where you can read more about this network. This was the last physical meeting that took place in Geneva in 2017, and both Eduardo Herrera and Hideo Tatsuzaki actually took here's Eduardo, took part in this meeting. Last meeting was held in last March, and it was obviously a virtual meeting with 235 registered participants. Biodosimetry network brings together some 80 plus laboratories worldwide, which are specialized on biological dosimetry, and this is put in place with the view of support to some potential mass casualty event to support the workload with biological dosimetry. We have conducted 3 surveys already for the capacity of the network, and the last survey was finished in January 2021. We had a bit reduced response rate, but we believe that number of our laboratories are involved probably in PCR testing for COVID. So these are the key functions of our expert networks. First of all, to support WHO's work in response to actual emergencies. Secondly, to support our work in building capacity through training, exercises, and development of technical tools and practical guides, etc. And the third very important function is to help WHO to implement IHR in countries. We contribute to the relevant IAEA international standards and guides and technical reports. In addition, we develop our own publications, obviously, technical reports. And what I would like to point out is the new document, which is a framework on for mental health and psychosocial support in radiological and nuclear emergencies. This document has been long overdue. We've been seeing the reports on non-radiological health impact of Chernobyl and Fukushima, which were reported to outweigh direct impact of radiation on human health. Also, we know that GSI Part 7 Requirement 16 acknowledges the need to make provisions and address psychosocial impact of this type of emergencies, but we still did not have a good practical tools explaining and helping decision makers how we can actually tackle this impact of emergencies. So we paired together with NEA, and in a collaborative manner, we started this project in 2018, and the document was developed in the framework of that project by WHO and published last year in November. You can download the document from this link, and here you can watch a video of the webinar when we presented the document and launched it in November. So at the moment, we are now working with NEA and with our collaborators in collaborating centers for developing derivative products, practical tools, Q&As, checklists, etc., to implement the framework. The 2017 Untitled blocking has been translated to a number of UN languages and non-UN languages. This year we are finishing the Portuguese translation. Our collaborating centers are actively offering training courses in different parts of the world. For example, some of these recent examples are shown here in China and in Turkey last year. What we're doing, obviously, like everybody else these days, we are conducting topical REMPAN webinars, which we started even before COVID back in 2018. And we just had a joint webinar with IAEA in April, and this is the second joint webinar, and I hope we will continue covering important topics of interest for the global medical community. And as you know, at Fukushima, we just marked 10 years since the Fukushima accident, and there were a number of benchmark reports prepared, and WHO contributed to a number of activities commemorating Fukushima 10th anniversary. I think this is my last slide. Yes, thank you very much for your attention.
Thank you very much for a very comprehensive lecture, Dr. Zhanat. So I would like to move to the next lecture. So let me introduce the next lecturer, Dr. Helena Reis. He's a medical expert in nuclear and radiological emergencies at the Institute for Radiological Protection and Nuclear Safety, IRSN, France. He was technical officer of this publication and worked at IEC as a medical emergency preparedness specialist. He has a lot of experiences for training courses to healthcare professionals at national and international level as lecturers. He will be lecturing on medical management at pre-hospital levels. So Dr. Helena Reis, floor is yours. Sorry, I will move to presenter role. Sorry.
Can you hear me now? It's okay?
Yes, it's okay.
Okay, sorry. So, well, on behalf of the Institute for Radiological Protection and Nuclear Safety in France, we would like to thank you, Mai, and Ramon, and Zhanat for this kind invitation to the webinar. The IRSN is a long-term partner of both organizations. We have worked together and contributing significantly to the medical response in different radiological accidents. We are part of REMPAN, we are part of RANET, and in the preparedness area, we have also contributed to the IAEA and WHO in the medical publications, in trainings, workshops, and most recently in the capacity building centers project with the IAEA. So thank you for the invitation once again. Regarding the topic, well, I will mention a little bit about the pre-hospital levels, the medical management. And for that, I would like to take this slide from the IAEA. When we have the spectrum of nuclear and radiological emergencies, we can have emergencies related to external exposure. When there is basically an irradiation, we are not in contact with the substance, or this is not an open radioactive source, but we are eventually irradiated because the radiation crosses our bodies or part of our bodies, and this can also have severe consequence for the health of the individuals. And the contamination is when the open sources may be incorporated through inhalation, ingestion, absorption by the skin or wounds. When we have these two constellations, we can also have combined emergencies, which in addition to these two hazards are combined with trauma, with explosives, or with another kind of accident. With this base, I would like to call your attention to the goals of the medical response in radiation emergencies. The first one is to save lives and perform required emergency medical procedures. the safe living procedures is the most important task in any medical response related to radiation emergencies. A second one is to treat the radiation injuries. All the radiological concerns are secondary respect to the stable patients or unstable patient. According to the main condition of the patient is the most important. And the third action is to perform the required public health actions and long-term medical follow-up of those exposed. Regarding radiation units and doses, we know that the energy and mass are related, and with this we can have changing the units, joules, kilograms, we can have grays. We have quantities used in radiation, but for the pre-hospital response, this is a nightmare. So in fact, we will not use any of these units, at least for the medical response, when the responders have no experience in this. Is relevant, or is not very significant that they know all the details of all these doses, equivalences, and exposure on activities, because it's something that will mislead the response. What is very important in the response, in pre-hospital management, is first, the identification, the triage, and the communication. These are the three main functions of any pre-hospital management. In the identification, we have to identify accidents or incidental situations. In the triage, life-threatening conditions are priority. Radiation will not induce immediate effects. And the third aspect of importance is the communication, because the communication with the incident commander in any emergency or with the hospitals requires a very strong coordination that will benefit the response and will do it more effective. In the identification, the experience demonstrates that several radiological accidents were firstly identified by medical professionals. So one of the most important tasks of the pre-hospital is to try to identify if there is any radiological or nuclear concern. For this, the United Nations have developed different receptors or symbols that are mandatory when there are transport, or when there is an area that could be potentially irradiated, or these symbols should be identified as soon as possible and communicated to the incident commander or the respective authorities. And the triage should be based on conventional parameters. Immediate attention will be always aimed at life-threatening conditions. The stabilization of the patient should occur before any decontamination attempt or in parallel, and the diagnosis might not be immediately apparent. So for triage, I will not go deep in this, but there are different systems. You can apply the system that is more convenient to you or that is regulated in your country. These are just examples, the START triage or the bicolors, as in the medical area, we all know we are related to level 1 resuscitation, level 2 emergent, level 3 or yellow code urgent, and green not urgent, level 5 non-urgent. Why I say that, that the diagnosis might not be apparent? Because of this. This is the evolution of a local radiation injury. And the day number 3 of this patient, this is the accident in Ventanilla. The patient developed a redness area, and you might see hypopigmented areas in the center of the picture. And the day 12, this is a mistake, it's day 70, the third image, and the day 196. So you see there is a long evolution, and probably when there is the first sign of a local radiation injury would be probably just a redness. So the preparedness team, the first responders, should be aware on do a proper anamnesis or try to find elements in the story that may lead to the discovery of or identification of a local radiation injury or exposure. In the case of contamination, we have many lessons from the Goiânia radiological accident, and you can see in this picture that only at 25 days, this is very late, and these are very extreme cases of contamination. Of external contamination, you will see symptoms or clinical signs very late. The same with this case that will be discussed later on by Mr. Daniek, Dr. Daniek. In this case, the patient presents alopecia on the day 7. So initially he presents some mild symptoms, some generalized unspecific symptoms, but it's very difficult to find out that a person could be contaminated if we do not use detectors. So the clinical signs may develop days after the exposure. In these cases, the cancer risk is maybe more important than it's an important component that should be elucidated with a multidisciplinary team. And however, even though this with irradiation or contamination, the lesions appear after several days, there might be initial clinical manifestations unspecific that the pre-hospital people or staff should be aware. This publication, Safety Report Series 101, we have the methods for early diagnosis of radiation injuries. You will see the time of onset. When you take a look on the clinical observations, nausea and vomiting are the earliest sign of irradiation, thinking on a whole body irradiation. Erythema may appear in hours to days, and epilation is certainly very late for the times of a pre-hospital response. The laboratory examinations, you will not do it on the site on the scene of an accident, but is part of the hospitalary management. And the cytogenetic, based on the lymphocytes, will also take hours to be ready, the results. And there are limitations because not all the countries have these techniques available. So basically, the radiation injuries, the main symptoms that you will develop and you may catch as first responders are nausea, vomiting, and eventually erythema. We mentioned identification, triage, and this is the third role of the pre-hospital, the communication. Provide key communication have a great importance for the development of an efficiency of the entire response. This will allow to other colleagues to wear PPE adequately and to prepare eventually the hospitals to do an effective management. So with the question, okay, we are handling nuclear radiological emergency right now. Am I safe? This is a recurrent question that needs to be addressed early at the stage of preparedness, because with that, the first responders will have more tools and will understand the risk that they might be exposed. But to your tranquility, in all the radiological accidents that have occurred, there have never been doses over the occupational exposure level to responders in the medical area. So you can handle patients immediately, and the life-threatening conditions are mandatory as the first priority. When we saw the flow management of a radiological accident, we have the accident, identification, very important, the notification, and then the triage and the hospital. This will depend on the number of casualties. If you have one individual, you will have much more time, or 2 or 3 individuals, you will have time to do a proper anamnesis, to maybe take a look on more details. But when you have a mass casualty event, the time is gold. So we know that the seriously injured people require stabilization. When there is a life-threatening injury or life-threatening condition or unstable patient and cannot be stabilized on-site, first priority is to transfer this patient to the hospital. Those not seriously injured or uninjured will be another group. With these ones, you can work more and do more measures, but those with life-threatening conditions should be transferred to the hospital as soon as possible. We said these life-saving actions are the first one, independently of the level of contamination or independently of the radiological accident. In this photo from NIRS, you will see that the professional staff are addressed. This may not be always in all the countries the situation, but life-threatening conditions are priority. When you have injured people that are stable, you may have or do more things at the scene before the transport. First of all, remove the contamination clothing at the accident site is a measure because you will reduce the level of contamination maybe to 80% or 85%. Remember, when we are dressed, we are kind of protected. So the area exposed are the head, the hands, and we are in summer are different conditions. If we are at the beach, it's totally different, but normally you are dressed, and taking out the clothes will be one of the first effective measures in the treatment of this patient. Cover contaminated wounds. Probably you will not have time in a mass casualty event to start to decontaminate the wounds at the scene. So the important here is to cover the wounds to avoid the spread of the contamination and transfer the patient as soon as possible. Even if you cannot take out the clothes or the patient is fully contaminated with radiation, if you cover the patient, you will reduce the spread of the contamination and you will support an effective response because these procedures can also be done at the hospital. So the third group, what do we do with it? Uninjured or the worried well? Those people that might be related to an accident or might be close to an accident and really are not affected or are maybe not injured, not contaminated, but they are concerned. From the radiological accident in Goiânia, and the same as many others, several lessons were obtained. In the case of Goiânia, the people was screened in an Olympic stadium that was conditioned for the screening of the population, and that's why 120,000 people were screened. From this publication from the IAEA, we mentioned about the radiation monitoring units that are basically gymnasiums or big areas that you could conditionate to do the screening only for those uninjured people or the worried well, because you will not send here a patient unstable. These are reserved only for those patients that have minor injuries. The protective of the first responders is very important. Not in all the countries you will have this exemplary protective, but it's important, the principles. The principles are, you have to cover your eyes, you have to cover your hands, you have to cover your clothes, and you have to seal, you have to avoid the contamination coming into your body. Ideally, use filter mask to breathe in, filter air, and of course, use the personal dosimeter. These are ideal conditions. Closing my presentation, I would like to call a document, an article from Dr. Finkel from 1956 that I found yesterday from the Journal of American Medical Association, JAMA. He said in 1956 that radioactive materials may be accidentally introduced into the body by inhalation, ingestion, injection, percutaneous absorption, or contaminated wounds. Concepts that are valid still. Second concept, medical and other personnel, if they have sustained some degree of skin and clothing contamination as a result of the treatment efforts, discard the clothes and bath. Take out the clothes and bathing is still a concept valid for the pre-hospital and hospital staff. Third one, it would be imprudent to leave unrecognized the importance of fully trained and organized staff of personnel. Training and education is one of the most important aspects for preparedness. And the fourth one, assistance from qualified radiobiologists, chemists, and health physicists, because the medical response to radiation emergencies is not only medical, it includes the entire medical team. It's a multidisciplinary approach, and this is a very important concept that's still valid. As conclusion, as Dr. Finkel said, education and training, basic. Triage and stabilization, remember to save life and perform required emergency medical procedures. And third, multidisciplinary work. The response to nuclear and radiological emergencies is always multidisciplinary. I would like to acknowledge my colleagues. Thank you very much. Merci beaucoup. And May, the floor is yours. I return to you.
Thank you very much, Dr. Herrera. Very informative lectures. So let's move to the next lecture. So let me introduce the next lecturer, Dr. Tatsuzaki. I will move to the role. Okay. So he is a medical doctor and is the director of the Department of Radiation Emergency Medicine, National Institute of Radiological Sciences at QST, Japan. QST is designated as a core center for coordinating and guiding for advanced radiation emergency medical support centers in Japan. It will deploy expert organized special task force and provide medical care for victims exposed to ionizing radiation from the nuclear or radiological emergencies. He has many decades of experiences in medical preparedness and response to these emergencies. So he will be talking on hospital preparedness and management. So Dr. Tatsuzaki, floor is yours.
Thank you for introduction, Mai, Ramon, and Zhanat, and also for invitation. Now, can you hear me?
Yes, we can hear you.
And you can see my slides, okay?
We can see slide, but not full screen.
Yep. Okay. How about this?
Yeah, now is okay.
Okay, so I will talk about the hospital level of preparation after transportation of the patient from the on-site to the hospital. Now, again, my name is Hideo Tatsuzaki, working in the institute so-called QST in Japan, and this is the core hospital and the Japanese management system for nuclear disaster. Now, my talk is based on this document, which is under preparation for publication, as Mai said, and EPR Medical 2019 generic procedure is currently the draft version. Now, considering the flow of a patient in the hospital, first, there should be radiation emergency, probably outside of the hospital. And you need to identify the accident or that incident. And then you receive notification and verify it. But sometimes the notification is coming from non-regular route, such as mass media, or even if the location of your hospital is near the site, the patient may come before any identification or notification. Now, after receiving notification, you need to activate the hospital plan. That means you need to prepare the plan to handle this kind of emergency well before the accident. Then based on that plan, you start preparation of the hospital. which I will mention in detail later. One of the topics in the preparation is contamination control. And actually, it depends on the types of radiological accident. If the contamination is not severe or very, very minor, or only the exposure of external radiation, you may not need to control the contamination, but probably you need to prepare just in case for contamination. And after preparation, you receive the patients. And first, you need to stabilize and treat, and if necessary, transfer patients to the referral hospital or high-level hospitals. And then after patients leave that site or outpatient clinic, staff also can exit from that area. Now, Eduardo and Mai also showed this kind of pictures. There are 4 components of or types of injury in the victims, but sometimes it's combined together. And also, I will mention about worried well later, and which is also sometimes coming to the hospitals, and it will cause consume the resource from the hospital. Okay. Now, as I said, this is a previous publication, EPR Medical 2005, and the current version is, of course, based on this previous publication. So my lecture contains basically following that document, and I will briefly mention about overview section, especially 262 hospital level and 263 referral hospital level. But mostly, I will explain about procedures. In this document, EPR Medical 2019, there's a code, the chapter called procedures, and inside you can find section B, procedures at the hospital. And it contains procedures in types of radiation victims, and they explain the procedures step by step. So basically, I will select essential points or keywords from each procedures. Now, before starting my contents, this is my impression of new document EPR Medical, comparing with EPR Medical 2005. That's an update, so basically the structure is the same, but the major improvements from my standpoint is the new publication avoided description according to organization of occupations. For example, the first responders, the role or medical response initiator, etc. I think this is a good direction because this kind of organizational structure is highly dependent on the countries. And the second difference is the new document removed detailed data for internal dose assessment. And of course, these detailed data is necessary, but probably it's only used by health physicists or medical physicists. And for the scope of this document, you can always refer to other document. Other minor improvements is, for example, the highlighted medical follow-up or also neutron exposure's weight was a little bit lessened. And it defines the national health authorities, also compared chemical and biological hazards, also more stress on radiation protection, and refer to OILs, Operation Interventional Levels. Now, forward planning of accepting patients to the hospital, these are the important points. First, you need to have facilities and capabilities to receive patients. And these facilities and capabilities are especially for having function for the contamination. Also, it needs to be prepared for acute radiation syndrome and having the cooperating drugs. Also, the function of radiological survey, and for those activities, you need staff properly trained or team properly trained, and as I said, you need to have plan or manual and educated staff. Now, in the section of overview, under 262 hospital level, this shows the present examples depending on local assets and equipment availability. So I think this is only example of procedures. And although the document shows you the essential point, you need to modify it according to your local conditions. Now, in this section, it's define or describes the role of these players, including medical response initiator, emergency medical manager, hospital emergency response team, health or medical physicist, radiological assessment team, and specialized laboratory support. I don't go every roles, but I just picked up the hospital emergency response team. Ideally, the team needs to include the team coordinator, the emergency physician, triage officer, nurses, radiological support personnel, technical recorder, and public information officer. This is because this kind of radiological accidents are quite sensitive to public, and always media people come to your hospital, ask many questions, so you need to prepare for that with public information officer. Also, you need to prepare with security personnel and laboratory technician and maintenance personnel. Sometimes you need to refer the patient to appropriate department within the hospital or relocate patient to referral hospitals after stabilization. The radiological protection team or support group work jointly with emergency response team. So this kind of explanation was explained for other types of response team or players. Now, inside the procedures section, it's a section B1, that's initiation of hospital response. The emergency medical manager's role includes manage participation of specialists. And he or she needs to decide whether transfer patients to referral hospital or see them in your hospital. Also, emergency medical manager needs to provide information through official channel to relevant authorities, update information, and of course, TOC needs to activate staff and the hospital itself. Then in the procedure section, the document describes the action needed step by step, like that. I again just pick up the key points in these steps. For initiation of response, you need to prepare for personal protection actions. Especially, you need to prepare for PPE, personal protection equipment. That means you need to close properly, wear the protective suits or gowns, which I will mention with the figures later. Again, in the step 4, the medical managers needs to notify public information officer, especially for rapid media response. And the step 5, communication was stressed. That was the same as pre-hospital level, as Eduardo mentioned. Especially, you need to communicate with National Health Authority. Now, this is another types of personal protection equipment. Eduardo showed kind of cover-all types. The most probably famous one is Tyvek suit by DuPont. But we used to use this kind of suit, which is, as you can see, the operation suit. And one difference is, of course, you need to wear the personal dosimeter and also use double gloves and eye shields. And the junction of this part is to be taped. Regarding communication and information, you need to get information about medical status, of course, and also radiological status. For example, the victims are exposed or contaminated. Also, if the patient surveyed before the hospital, in that case, the existence of contamination or no contamination. And if possible, identify the contaminant. That means nuclides. Also, we need to know the previous treatment, such as potassium iodide, DTPA, or other medications. And of course, you need to know the arrival time of the patient. And the procedure B2, the document described reception of causality at the hospital. The following information needs to be considered. The number of patients and also their medical status and the radiological status, as I said. And also, you need to start check the hospital arrangement. Especially in many cases, you need to prepare for a special entrance for, especially for contaminated patient. And regarding valid well, the valid well means there's basically no contamination, no injuries, but these people are very, very concerned about radiation exposure. And they may come to your hospital seeking medical attention, but they can cause extra burden to your hospital. So coordination with other medical facilities and send them to other facility is probably the one important procedures if the situation allows. Now in procedure B3, the assessment of casualties ambulance reception area. You need to consider medical condition, especially in case of combined injury, the triage patient for medical management and radiological survey, and you start contamination control and radiation protection. The essential point is first considering the medical side and then to radiological programs. Now, first to medical means if the patient have life-threatening condition, then you start to stabilize patient and postpone radiological survey to later stage after stabilization. That means you need to treat patient principally according to the health condition. And triage needs to be done at each stage. Urgent clinical intervention always have priority over radiological concerns, and immediate attention is directed to life-threatening problems. Because radiation injuries rarely cause the severe reactions like unconsciousness or immediate visible signs or injury. That means these are not immediately life-threatening. Procedure B4 describes contamination control in hospital. And in this procedure, in case of mass casualties, you need to assess public for possible contamination. Again, the individuals who are only externally contaminated but not injured are best decontaminated at facility other than the hospital to save hospital resources. Then, to accept contaminated patient, you need to prepare for a pass from entrance to the treatment room with covering. Or also, you need to prevent unauthorized entry of non-related people. In the hospital treatment area, again, you need to restrict access to these areas and probably relocate non-acute patients and remove unnecessary equipment or cover unnecessary equipment. To avoid spread of contamination, you need to cover floor. And then in step 5, you need to prepare survey instruments and check background. Also cover treatment table. And our advice is to use several layers of seats, because if the first layer is contaminated, then just remove that seats. And the step 4, you need to prepare for waste containers with large plastic bag. And regarding ventilation system, desirably, if you have separating system for ventilation from rest of the hospital, that's better. But actually, there's little likelihood of contaminants suspension in air. Now, in case you discover contamination after patient admission, that means no previous knowledge of patient contamination and the patient came and then you notice the contamination. You need to establish control line. But again, you need to perform actions necessitated by patient's medical status. This is an example of zoning or area setting. Actually, it's a picture of my institute. And this line, red tape, shows so-called hot zone. And we try to contain all the contaminants inside this area. Actually, in this picture, it's too small and you need more space. That means the medical doctor or medical team needs to move around the patient in this line. So you need to expand the hot area a little bit more like this one. You need to prepare for containers and cover equipment like that. And you can notice the cover up of the floor with plastic sheets and paper in this case. This is the hot zone, and we call it the warm zone outside, or sometimes semi-hot zone. Now, this figure shows the procedures divided by the occupations or roles. And I will skip these pictures. And this is one of the example of treatment area and triage area. Basically, you need to triage patient and treat contaminated patients different line with non-contaminated patients. This is if you don't have time to cover all the floors, then you need to cover the part of the floors like that. Now, to decontaminate the skins, it is better to cover up non-contaminated parts first and wipe or irrigate the region. In case of wound contamination, again, cover other parts, non-contaminated parts, and wipe and irrigate with running water. For normal skin, you can use detergent or soaps or shampoo. Now, at the hospital, you need to take many laboratory samples, and this table shows the necessary samples like complete blood counts or urine or swab from facial orifice, etc. You can refer to this table. Now, the step before, it describes the reaction to external exposure. Just with external exposure, it's not additional risk to medical personnel. But in case of criticality accident, the neutron cause activation. So the patient can have some radioactivities, but actually, usually it's not significant hazard to medical people, medical teams from the past experience. Even in that case, you need to perform radiological surveys to confirm non-contamination. This shows vomiting and nausea, but I think Eduardo already mentioned about these things. And it depends on the symptoms and the counts of lymphocytes. You can roughly decide treatment strategies. If the admission is needed or with the high probability of lethal outcome, you need to have very high intensity care. Again, the external exposure, cytogenic dosimetry, and absolute lymphocyte count is good tool for dose estimation. This was also explained by Eduardo, but temporary ablation or dry ablation, this kind of skin reaction can use for dose estimation. This table shows lymphocyte count versus prognosis. And then procedure B5 describes the contamination. The important point is you need to wear PPE, personal protective equipment, as I showed. And the order of priorities are first wounds, and then orifices, then highly contaminated area to less contaminated area. For wounds contamination, as I said, first drape wounds, and be careful not to move radioactive materials into wounds. Rest of the procedure I already explained with figures, so I will skip it. And the body orifice, like eyes, you have special technique to irrigate that part. And that was described in this table. For management of internal contamination, this was actually described more deeply by Dr. Daniak, so I will skip this part. But of course, the document includes description of internal contamination. Now, lastly, after the patient leave the area, you need to recover that area, that including the waste management. You need to collect radioactive waste in plastic bags like that and isolate it from the hospital staffs. Then all the staffs remove PPE and do survey before leaving the area. Now, this is, I think, the last slide. The most important thing is treatment priority. And Eduardo and me stressed many times, medical treatment for serious conditions always take precedence over decontamination. Contamination is never an immediate life-threatening condition, which is most important take-home message. Okay, thank you very much.
Thank you very much for a very informative lecture, Dr. Hideo Tatsuzaki. So let's move to the last lecture. Let me introduce the last lecturer, Dr. Daniak. So I move to roll to, sorry, please wait. Okay, I move to role, the presenter role. So he is a clinical professor of medicine, Department of the Therapeutic Radiology at the Yale University School of Medicine. He has a lot of expertise in medical management of individuals involved in nuclear or radiological emergencies. He also has advised US and foreign government agencies and professional societies on medical management of radiation injury, and also serves on working groups and task forces for IAEA, WHO, NCRP, and so on. He will be lecturing on approach to the diagnosis and management of internal contamination. So Dr. Daniak, the floor is yours.
Thank you very much, Mai. I'd like to thank the organizers of this webinar for inviting me to participate. Can you see my screen?
Yes,
all right?
we can hear you and we can see your screen.
Very good, thank you. So my objectives here are to review the routes of radionuclide intake and tissue distribution. And what I would like to do also is emphasize the importance of obtaining accurate clinical information and understanding that dose estimates of internal secretions that were mentioned already by Hideo and Eduardo, that is very important. And we obtain these samples from the face, nose, sputum, urine, feces, and skin. I'd like to review how you understand the relationship between a dose to the body organ versus a whole body dose, and then in general terms, describe medical countermeasures. Let's see if I can get this to down. So these are the routes for radionuclide intake and distribution, and I would like to start with inhalation. So when radionuclides are inhaled through the respiratory tract, they're transferred to a transfer compartment. This is typically the blood or circulation. Parts of the radionuclides are actually moved into the tracheal lymph nodes and then into the transfer compartment. And from the transfer compartment can be moved into the gastrointestinal tract, excreted in the feces, or it can be removed by the kidney and excreted in the urine. The way we initially look at dose is to look at dose magnitude. This is a concept that was developed by Steve Sugarman and Dick Toohey. And it's an important concept which looks at the question of, is this a significant dose? And what we use are the inhalation annual limits on intake, as well as clinical decision guides that have been developed by the NCRP and ICRP. We assume for nasal swabs that 5% of the deep lung intake will be present on the swab. We also look at nasal blows, surveys of the face, sputum, spot check of a urine, but most importantly, medical history and physical exam. So it's important to know whether the patient is touching his nose and moving radionuclides from one nostril to the next, whether he's expectorating sputum, and if so, how much, and can we collect it? So in the case of inhalation. So basically, we then use our counts, our CPM, and convert it into depositions per minute, or DPM, because these annual limits are recorded in DPM. And we use the gamma ray constant for that particular radionuclide to make this conversion. Well, how do we convert a tissue dose to a whole body dose? Say a patient who's receiving a lung dose of 4 millisieverts. It's very easy. We look at the tissue weighting factor, and these weighting factors have been determined by NRC, NCRP, ICRP. And in the case of the lung, we know that the tissue weighting factor is 0.12 for each of those organizations. And we basically multiply the tissue weighting factor times the lung dose. So for this lung dose of 4 millisieverts, multiply it by the tissue weighting factor, we have a whole body dose of 0.48 millisieverts. So the detriment or the risk from a lung dose of 4 millisieverts is the same as that of a whole body dose of 0.48 millisieverts. The radionuclides are deposited are deposited and distributed throughout the respiratory tract based on the particle size. So as we go down from the trachea, we're at centimeter levels, and then we move into the main stem bronchus and the lobar bronchus, and now we're at right at 1 centimeter, and then we start to get into millimeter levels as we get into segmental bronchi and bronchioles, and then down into half of a millimeter when we get down into the alveolar duct and the alveolus. If we look at the particle diameter, the diameter of 18 to 20 micrometers would be deposited primarily in the nose. As we get down into 7 to 12 micrometers, we're moving into the main stem lobar bronchi. And then we get down into 5 micrometers and less, we're moving into the alveoli. So the important point here, and this is concepts that have been developed by Al Wiley, is that the clearance time varies depending on particle size. So clearance time is very rapid for large particles. And then as you get into intermediate sized particles, it starts to get into hours. And then as you get into the less than 5 micrometers, we look at a clearance time of 100 days. So there's a significant amount of radioactivity that will persist for a prolonged period of time. Treatment includes DTPA to remove the radionuclides. Calcium DTPA is given once. It's a very efficient, effective mechanism to remove the radionuclides, and then zinc DTPA. And this is for actinides. We can also use it in a nebulized form by diluting 1:1 with sterile water. It's important to know that you should not use calcium DTPA. In other words, go straight to zinc DTPA in pregnancy, because DTPA is a category C drug, and that is known to cause teratogenic effects in animals. The next, let's see if I can get this down. I'm trying to move this. Sorry about this. I'm not able to move this screen down a lot. There are other agents, new agents that are being developed and have been recently made available. HOPO ligands. HOPO ligands may be more effective in removing radionuclides, in particular actinides, than DTPA. They've been developed both within the US as well as throughout the world. These HOPO agents can be modified by placement into nanoparticles, and also can be chemically modified. For example, adding a methyl group between two sides of the molecule in order to enhance binding. This is an area of active investigation. Well, another method is of treatment, early treatment, is to use bronchiolar alveolar lavage to remove alveolar material. And this technique requires the use of a flexible bronchoscope that's passed into the lung and into the smaller airways. And using a double lumen tube, one can actually push fluid, saline, for example, or sterile water into the lung. And then with a double lumen tube, changing the stopcock, you can then remove the fluid, aspirate it out. And you can collect very good samples. In this case, these are normal cells in the bronchial fluid, in the BAL fluid. So therapy directed at the respiratory tract includes using radionuclide-specific therapy. You can use ion exchange resins, such as Prussian blue, or chelating agents that we've talked about, DTPA, and physical removal of insoluble particles of having high activity radionuclides, typically iridium-192, strontium, and polonium. This should be done in selected patients by an experienced pulmonologist or thoracic surgeon. And we need to do studies looking at ideal goals for BAL and efficacy of BAL. And these studies probably should be done in large animals. This is an area of need. With all of that said, it's important to know that you should medically stabilize the patient before addressing internal contamination. No one dies from contamination per se. Let's move to the next pathway, which is ingestion. Ingestion through the GI tract, then absorption through the circulation into a transfer compartment, movement into the liver, and then excretion into the feces, or excretion via the kidney into the urine. So let me present a case. This is Edwin Carter, a 43-year-old man who presents to the emergency room with abdominal pain and severe vomiting and diarrhea. And the patient is diagnosed as having viral gastroenteritis, is given fluids and an antibiotic, ciprofloxacin, and then comes back to the hospital a few days later and is hospitalized because he has persistent symptoms. On day 5, he's noted to have a low platelet count. On day 7, a Clostridium difficile toxin comes back positive, and he's treated for that. The patient and his wife also bring up the possibility of poisoning, and they measure a thallium level, which is above normal slightly, and he's diagnosed as having thallium toxicity, and he's treated with Prussian blue. A few days later, the patient develops neutropenia, and then develops an aplastic bone marrow, loses his hair, and develops mucositis. Liver function starts to deteriorate by 2 weeks, and then the patient is given GCSF. As well as antibiotics. The fever persists, and antifungal agents are added, as well as antiviral agents. And then the patient's kidneys begin to fail. The patient is most likely drug-induced, but we don't know that. And then the patient has an abnormal EKG, transferred to the ICU, and then undergoes 3 cardiorespiratory arrests. And between the first and second arrest, a procedure is done. And then the patient at its 3rd arrest dies. So this is the bone marrow aspiration and biopsy, showing that it's an empty bone marrow. There's no cells in here. It's just all fat. And this is the procedure that was done the day before death. And basically, it was to take a peripheral blood smear, cover half of it with a cover slip, and send it for a radiograph. And notice that the radiograph our positive material is totally blocked by the cover slip. That suggests we're dealing with an alpha emitter. And based on that, the patient has then urine analysis to show that this is polonium-210. As you know, this is Litvinenko. And the activity in these various tissues, peripheral blood and urine, are dramatically high, and becquerel. And on autopsy in the lung, liver, kidney, and skin, dramatic elevations. In fact, this patient had enough polonium-210 that would equate to several thousands of millions, or 10 to the 9th becquerel, okay, or a few gigabecquerel. So no matter what, this patient was destined to die. So looking at how we assess intakes, we can use whole body counting. We don't have a lot of these machines around, but they can be useful for penetrating X-rays or gamma rays. And we can use bioassays of the feces and urine is most widely used. One can do back calculations of the urinary activity to estimate the activity that initially entered the body. This is often done after discontinuation of therapy. And that brings me to the 3rd case, which is a wound case. That is absorption of radioactivity via a wound through subcutaneous tissue, then transfer to the transfer compartment, excretion in the kidney, or into the GI tract, and both, actually. So I would like to bring up a case that we published in 2018 in Health Physics. And it's a puncture wound of a person who was flagging canisters or venting canisters that contained plutonium-238. During the process, he punctured his hand, and here is the wound. And ultimately, this wound up to show the 13, 17, and 20 keV emissions of plutonium plus americium. The patient had a mapping done, which showed that the 50% of the activity was located fairly close to the wound, and another 25 and 25% adjacent. The patient then had an excisional biopsy, so that the material around the wound was excised, And then the activity of plutonium-238 was determined, and this is before and then after excision. So this was a good mechanism to remove a significant amount of radioactivity. The patient was then given DTPA, and these are urinary measurements. You can see initial urinary count was 24,000 DPM, and by comparison, a value of greater than 1 is considered to be significant. And the patient had then levels, urinary measurements done before and then after DTPA, showing that DTPA was actually working well, moving the radionuclide into the urine. And then after chelation therapy, 300 days worth, chelation was stopped, and then for 100 days, and then a baseline without DTPA was then measured, and based on this baseline, one could back calculate the original dose, so that the initial cumulative effective dose was calculated to be 31.5 rem, and then the averted dose, the dose that we averted by therapy, was 15 rem by the excisional biopsy, plus 100 rem by DTPA. Well, there are other therapies, of course, depending on the radionuclide. We talked a little bit about DTPA, predominantly the actinides plus cobalt, Prussian blue, which is an ion exchange resin. We've talked about its use in thallium. It also is the treatment of choice for cesium. And then barium sulfate, aluminum hydroxide, calcium phosphate, they all inhibit GI absorption, which is important for radium and strontium. These are bone-seeking radionuclides. We alter chemistry by and then we hydrate for tritium. Of course, we block iodine uptake with KI for thyroid. So what I've tried to do is describe for you that the fact that good clinical acumen, looking at clinical signs and symptoms, as well as measurement of internal secretions, is important in initial assessment of internal contamination. We can convert or develop a dose estimate for a radionuclide by converting CPM to DPM using the gamma ray constant. Dose magnitude is determined by comparing our estimated dose to the annual limit on dose, ALI, or CDG, clinical decision guide, for that radionuclide. We can convert a whole body dose by knowing the tissue dose multiplied by the tissue weighting factor. We can estimate the initial dose by back calculation of a urinary dose. This is usually done after discontinuation of decorporation therapy. Management of internal contamination includes decorporating agents as well as physical removal of radionuclides. And we need to have additional research to fill gaps. One gap is assessing the efficacy of BAL in large animals. Another is to develop more efficient chelators, such as HOPO agents and modifications thereof. These are some references, including NCRP, Radiation Emergency Medical Management in Europe, the Medical Aspects of Radiation Incidents, a REACTS pocket guide that I revised together with Steve Sugarman and the other workers at REACTS in 2017. These are key publications by Sugarman, Tui, and that's the case that we published. And thank you very much for your attention.
Thank you very much, Dr. Daniak. Very informative and meaningful lectures. So let's move on to the discussion session. I will share the Q&A from the attendees. So please wait.
I answered several questions already.
Yes, yeah, I skip. You already answered.
Okay.
Yeah. So we received many questions. Can you see my screen?
Yes.
Okay. So first of all, this is questions to me. First question is when revision of EPR Medical will appear. So it is not decided, but this is the final publication process. So we are final editing, and so we hope this publication will be published within within a few months. And the next questions, why psychological support is not included is in comprehensive medical support already at the beginning. So in requirement 12 of GSR Part 7, in the main goal, it is not includes the psychological support, the word, but long-term follow-up includes the health consequences derived from it as psychological effect. And also in GSG 11, mentions that emergency arrangement have to be made such that both psychological counseling and continuous medical care can be provided. For this purpose, the organizations and facilities responsible for these services need to be identified at the preparedness stage. So this is very important, considering the psychological support, even for preparedness stage. So the next question is a question to Mai and Zhanat. First question is how IAEA and WHO operate to ensure their project and education on radiological medical management reaches third world countries like Tanzania effectively, and how they are going to conduct seminars live on these countries. So IAEA-IEC organize regional and national training courses and some kind of webinars and a TC project in EPR medical field. And most recently in 2019, IEC implemented the regional training course for African region and a TC project. So we will continue to implement these training courses. So we also try to translate the new EPR publication, EPR Medical and the EPR Medical Follow-up to another official languages of the United Nations as well as French. So the next question is, how do IAEA and WHO ensures medical physicists and other radiology courses are studied in the university levels effectively so as to have enough experts in such areas? So I think Zhanat already answered these questions. I add to my comment, IEC also published, IAEA also implement the training course for medical physicists and for nuclear or radiological emergencies. So we will support for medical physicists. So Zhanat, are you added?
Well, I'm not sure if our answers in the Q&A session, if they are visible to everybody or are they visible only for panelists?
It's visible, yeah.
Okay, so you can see the answer to this question, yes, where I mentioned that we worked with IAEA and IOMP, International Organization of Medical Physicists, back in 2015, 2016, with the NAHU Department of Nuclear Application for Human Health, which is a different part of IAEA. They developed a train the trainers course for medical physicists, and that's where we contributed and participated at the time. But you know, we really, WHO and IAEA does not have a power to impose anything on countries, but we advocate, we persuade, we gently can offer the options and demonstrate the benefits, but we don't have our own university to implement this type of training programs. But even in some countries, we know that medical physicists doesn't even exist as a specialty. So there is a lot of work ahead, and it's very important, and medical physicists have a very important role in healthcare facilities. So we think we could also take a look on how we can contribute more in this area.
Yes, thank you very much. So let's move to the next. So these are the questions to the Zhanat. First question is, I think out of this topic, but I read this question: how do we control the indiscriminate use of CT scan for COVID detection in certain countries?
How did this question came up? I didn't see it in Q&A somehow.
Yeah, this is in the chat.
Oh, okay, I missed that. Well, WHO is basically striving to ensure access to healthcare without discriminating to any groups or minorities or vulnerable groups. So the logo and our lead motto is health for all. And of course, radiation program of WHO, we're also working with the agency, with IAEA, promoting the safe use of radiation in healthcare facilities, promoting radiation safety culture in hospitals. I cannot say, unfortunately, more with this regard because this area is not my area of work. The use of radiation for diagnostics and for therapy in hospitals. And this is dealt by other group of colleagues in our department. So, but if you would like to know more about it, send me an email and I will put you in touch with colleagues who deal with this area specifically.
Thank you very much. The last question to Zhanat is: in case of the doctor trained in medical radiation emergency has retired, can the emergency response team of the country seek the assistance of the Liberator REMPAN possible radiation exposed?
Well, it's unfortunately we see the situations quite often when people retire, especially in lesser developed countries. Being linked to some international partners for the networks is seen in a way sometimes, unfortunately, as a possibility to have access to information. And people sometimes, human nature is such that people sometimes look at it as an individual benefit. But we try and we strive to have relations built with the organization, with the hospital, with the university, with the research center, rather than with the individuals. So for collaborating centers of the WHO, for example, we do regular checkups. If the management has changed, if people rotated, we keep up to date all the contacts. And of course, if a person has retired or changed the place of work and did not hand over the ongoing activities, by all means do contact us and we will be happy to reestablish the connection with new staff. Thank you.
Thank you very much. So next move to the question to Dr. Herrera. The first question is symptom of the radiation-related injuries, especially related to skin erythema, may vary based on dose level and type of incident radiation and which tissue of the body is exposed. So Dr. Eduardo, can you comment on this?
Well, I can, yes, the question is right. Several times the dose is will have a clinical expression when there is a very high absorbed dose, especially over 25 grays. We will have the risk of having necrosis. This has been demonstrated in the skin. For muscles, there are other thresholds for bone as well. For bone is 40 or over 40 grays. We will have radionecrosis, and this might not be evident in the first weeks or in the first month. Could be also years after, because the bone will have a delayed reply or delayed response to the radiation injury. So yes, the question is right. There are limits related to clinical expressions. However, for the first responders or for the pre-hospital response, it is very difficult to estimate these doses unless the first responder have some knowledge on radiation. And the only clinical expression initial that we will see is redness, erythema of the area exposed. So in few accidents, there have been other symptoms. For example, maybe Dr. Hideo Tsusaki can give more details on the criticality accident on Tokaimura, but in that case, the patient had a seizure. He lost the conscious in a very fast minutes, And this is another kind of exposure and exposure that you will not see in mass casualty events. So yes, it's difficult to estimate doses as a pre-hospital, and that's why the doses I did not consider so relevant for the pre-hospital response in my presentation. I hope this solved a bit the doubt. Thank you.
Thank you very much. And the last question is whether the revision of the 2005 EPR publication follows the 2005 model with few demands on scientific documentation and evaluation, such as the grade system from 2011. So do you understand this question?
I think I can answer this because grade,
okay, yeah, thank you.
Grade system refers to the qualitative assessment of the strength of the evidence, and any recommendations produced by WHO are supposed to comply with this method of scrutinizing the strength and quality of the scientific evidence, which is used as a basis for delivering recommendations. EPR Medical we consider as not as a guideline per se, it is a procedures book. So it basically tells what to do in a very detailed procedural operational type of information. So that is why we did not apply grade approach to this document revision.
Yeah, thank you very much. Okay, so let's move to the next the question to the Dr. Hideo Tatsuzaki. So I will like you to explain in detail the role of radiological support personnel and security personnel in the hospital emergency response. Can you comment on this, Dr. Tatsuzaki?
Okay. Yeah. Well, radiological support personnel is usually helps radiation safety officer to check the safety of that area, especially the ambient dose level, and also to check the contaminants flow out from the hot zone, for example. And security personnel is needed to avoid the entrance of non-related people, especially, well, not especially, but sometimes media people come into the area. So to protect this entrance to the contaminated area, we need to regulate the flow of the people. That's why the security personnel is needed.
Thank you very much. And the next question is, how
Okay.
effective? Yeah, okay.
PPEs. Probably I forgot to mention the important things. The PPE, person protection equipment, is the function is to avoid contaminants attached to our skin or medical person's skin. It's not protecting from external exposure. So that's why the protective gear is just a thin paper or thin clothes. So I think that's the intention of the questionnaire.
Thank you very much. The last question is that how radiation used for treatment, example, X-ray, can be controlled such that do not spread to unrequired area.
How radiation used for treatment, X-rays can be controlled such that. I'm not sure this question mentioning about the.
Yeah, I think this is radiation protection.
Yeah, is he or she concerned about medical use of X-rays? In that case, for example, the treatment area used in radiotherapy, then it has thick shielding walls, sometimes including the iron. But in the treatment room for radiation emergency, it's a regular treatment room. I mean, there's no shielding around that area. So actually, I'm not so sure about this, the meaning of this question.
Thank you very much. So this is last, sorry, I have no time to paste the question from a participant. So I read on the questions on the chat to Dr. Daniak. The first question is, I have a question. When doctors deal with the internal contamination patient, how to protect themselves?
How do you
Can
protect
comment
what?
on
I'm
this?
sorry.
Yeah.
I'm sorry. How do you protect who?
Sorry, I read one more. When doctors deal with the internal contamination patient, how to protect themselves?
Ah, I see. In a traditional way, you would use PPE that has already been covered. There are certain interesting facts, like we did talk about the wound contamination with actinides. And once inside the body, those actinides are really harmless unless you're touching the wound, which you don't want to do. So you want to use PPE that includes double gloving. If you're rinsing the wound out, you would want to use gowns, face masks, cover the eyes, etc., so that any material that's splashed around would not be in direct contact with you. But the interesting feature of actinides is that once they're inside the body, just like actinides outside the body without a wound are harmless. Actinides inside the body without that wound, okay, with it covered appropriately, are harmless as well. So you have to realize there's that benefit that the tissues, the normal tissues of the body, will protect someone who's managing the patient. Nevertheless, PPE is the right choice here, the right answer.
Thank you very much. So this is the last question. This is on the chat. They are very long from Nancy. Why for the medical management of internally contaminated people, there are no operational criteria to recommend their medical treatment in relation to, for example, the DPM in nasal samples?
There are no operational criteria. Is that what that was? That question?
Sorry. Why for the medical management of internally contaminated people, there are no operational criteria to recommend their medical treatment in relation to, for example, the DPM in nasal samples?
They're looking, I think that question is aimed at endpoints. Okay, when do you stop therapy? In other words, you treat up to a certain point, and then at some point there is a decision of when to stop. And that's a really good question. I'll use the actinide example for, which is that, well, what is the absolute best outcome? Well, it's zero. Can you ever achieve zero? Probably not. So when do you stop therapy? And that's an area of investigation. We don't really know. And I would guess animal studies looking at long-term sequelae from chronic exposure would be the best way to approach that. So we do it on a case-by-case basis. We stop therapy on a case-by-case basis. And a lot of that has to deal with logistics. Can the patient tolerate the therapy? Can he receive the therapy? Does he have the time and for therapy? Is the location of the treatment center, etc.? A lot of logistics come into play. But that's a really good question. It's an area of further investigation.
And also,
thank you very much.
Aligns with our future plans. Nick Daniak will be chairing the WHO Guidelines Development Group on management of internal contamination.
Right, and that's a good question for the group.
Thank you very much. I think that we can answer all the questions. Do you have any additional comment from external expert?
I would like to ask all experts to turn on cameras so we can take a screenshot.
Ah, okay. So please, this is my first time. so let's try to let's. Okay, view full screen. Sorry, please wait. Okay, so I will take screenshot. So please wait. Okay, thank you. Okay, so I would like to conclude this webinar. Thank you very much for attending this webinar. I highly appreciate Dr. Zhanat and Dr. Herrera Reyes and Dr. Tatsuzaki and Dr. Daniak for very informative lectures. So I think we continue to implement the webinar related to EPR medical field. Until we meet in the next webinar, please stay safe and healthy. Thank you very much. Bye.
Thank you. Thank you. Bye-bye.
Thank you very much.
Goodbye.
Thank you very much. Bye-bye.